I think the biggest challenge in sorting that out is the outcome in terms of amyloid lowering did not match the model, that about 25% or so of participants got below the cutoff of what's considered to be amyloid positive, and they projected to be more like 50%. So it wasn't, and they started at a higher baseline of amyloid load than what was reported with Lecanemab. So the degree of amyloid lowering was not as robust as expected. And that's unclear what caused that, if it was the formulation, the slow titration, the subcutaneous route of administration. The other drugs are given intravenously. There needs to be more PK data to see the correlation between the dosing and the clinical outcome, and also the amyloid lowering. So that all needs, further investigation. But that was disappointing. It looks like you need to have, at least from the data so far from Aducanumab, Donanemab, and Lecanemab, is that you need to have a certain degree of amyloid lowering in order to see a clinical benefit. And that is something the field is trying to determine what is that target, and how reliable is that. So that's an important outcome, because there's some additional analyses from the graduate program that shows that those that did get the highest dose, had the maximum exposure, actually had a good clinical benefit, or in the same range as we saw with other trials. And then in an Asian population that was a little thinner, there was greater exposure and better clinical outcomes. So again, it addresses this important issue of target engagement and how much amyloid lowering is necessary.